Hi, this is E.W. Crawford, Editor-in-Chief of Grand Rounds in Urology. There's been a lot of interest lately in upper tract renal cell or transitional cell carcinomas of the renal pelvis and some major advances in the therapy of this somewhat rare condition. Joining me is Dr. Sumanta Pal, who actually did his training at in medical school at UCLA, where I did my fellowship, and is now at the City of Hope Hospital. He's been very productive there, involved in a lot of research, publications, and is going to share with us a publication that just occurred in European Urology on this topic of upper tract tumors. Monty, thanks for joining us.
Hey, thanks for having me, Dr. Crawford. Really excited to talk about this recent publication in European Urology. Just as a little bit of background, upper tract urothelial cancer, we really do feel is far more aggressive than lower tract disease. And of course, many investigators around the country have contributed a lot recently to understanding the biology of it. One of the things that we're really coming to understand is that upper tract urothelial cancer has a different really sort of array of mutations than lower tract does. And in particular, and this is one of my areas of research focus, it seems to be enriched in alterations in FGFR3. Now, that varies from one series to the next. Serena Mateen at MD Anderson has performed a series in which he suggested that perhaps up to 70% of patients may bear alterations in FGFR3 in upper tract disease. Other series, such as that from Foundation Medicine, which I was a part of, have perhaps more modest estimates in the ballpark of maybe 40 to 60%. But what we do know is that certainly the frequency is higher than in lower tract disease. There are other mutations that are higher in upper tract as well. HRAS is one of those that kind of comes to mind as being a potentially targetable entity, but we'll get into that some other day. When it comes to FGFR3, there's a number of ways that we can actually block it. There's monoclonal antibodies that are currently in clinical development. In addition to this, I would say perhaps the more common strategy has been to use small molecules, just as we have in renal cell carcinoma, for instance, to target VEGF and MET and what have you. I've been involved for many years now in the development of a drug called infigratinib. Infigratinib was originally held by Novartis Pharmaceuticals. Now it's held by QED Pharmaceuticals. And the compound is a very potent and specific inhibitor of FGFR3. You may ask, why do we need another FGFR3 inhibitor? There's already a drug called erdafitinib that's approved for advanced urothelial cancer that's FGFR3 mutated. Seems to me like infigratinib may actually have a profile that lends itself perhaps a bit more to clinical practice. There's less in the way of hyperphosphatemia. That's a common class-related side effect with FGFR3 inhibitors. It's much easier to manage with infigratinib than with erdafitinib, in my opinion. There's other issues such as fatigue, eye-related changes, corneal changes that seem to be occurring with a lesser incidence with infigratinib versus erdafitinib. So I do think there's a pressing clinical need. We did a phase 1 study of infigratinib several years ago that we published in Cancer Discovery, suggesting response rates upwards of around 25%, stable disease rates that more than doubled that. So I would say very impressive data for a population of patients that was very extensively pretreated. We also had some nice biomarker work done in the study to suggest that, for instance, resistance can be evoked by the increase in circulating FGFR3, which we picked up in ctDNA and so forth. So, there's certainly some rationale to think that FGFR3 inhibition is not going to be a permanent, durable strategy. Having said that, we wanted to investigate further whether there might be other clinical biomarkers of response. So, as I mentioned earlier, hyperphosphatemia seems to be one of the indices or a class-related side effect with these FGFR3 inhibitors. We decided to put together a very thorough assessment of the pharmacokinetics, as well as the response associated with patients based on the incurrence of hyperphosphatemia. And lo and behold, and this should be, really no surprise, if you have higher levels of hyperphosphatemia, perhaps this implies, greater effective levels of drug. But ultimately, it lent itself to having a much higher response rate with infigratinib as opposed to those patients who lacked hyperphosphatemia. So moving forward, if you do struggle with hyperphosphatemia in the clinic with infigratinib, know that this may potentially be a biomarker of response. It's kind of like hypertension with Sutent to the VEGF inhibitors. So where are we going with infigratinib moving forward? And I'm really thrilled to talk about this with the urology audience. Basically, what we're looking to do is position infigratinib in a randomized phase 3 clinical trial. This is called the Proof 302 study. Me and Sia Danishmand at USC are running this trial. This takes patients that have documented FGFR3 alterations, and it randomizes patients to either infigratinib or placebo. So very important study. I would suggest that, at this point in time, the jury's still out there regarding what optimal adjuvant approaches are, but certainly in this population of patients that's FGFR3 driven, I think it makes a lot of sense to consider this trial. So as a final pitch here on Grand Rounds Urology, if you see a patient with FGFR3 alteration that's recently been to the OR, had their bladder or kidney removed, consider putting the patient on Proof 302. That's infigratinib versus placebo as adjuvant treatment. Very important trial, and thanks for tuning in.